sir.
হ্যাঁ, তুমি আমাকে একটু তুমি আমাকে বলো যে নুসরাত আমরা লাইফে গেলে বলো, দেন আই ক্যান স্টার্ট। সাকলায়ন স্ক্রিনটা একটু পরে শেয়ার করো, এখন একটু জাস্ট স্টপ শেয়ারিং, তারপরে আবার একটু পরে আসো। থ্যাংক ইউ
Sir, we are on live.
We are online. আচ্ছা জি, ওকে, থ্যাংক ইউ ভেরি মাচ নুসরাত ফর সাপোর্টিং আস। তো সবাইকে আবার নতুন করে আসসালামু আলাইকুম। So we having our vascular webinar today, and the topic is quite important one, which is the subclavian artery injury, which is not a very common injury we see, but we do see, but it's a very, very challenging problem which we need to deal with. So I think for all of us, having some sort of good orientation on this subject is very important. And we willing to elaborate this topic very thoroughly today. That's why, you know, we have the full dedicated session just on this topic today. So I first like to welcome our expert panelist here, and thanks one again, Dr. Abidul Rahman, who is from United States, is a very experienced vascular and endovascular surgeon, and we do get a lot of good knowledge and information from him. And you know, he is our big support, and he has been attending this webinar very regularly, and I'm very, very thankful that he gave his valuable time for us. Thank you very much, Abid Bhai, once again for joining us.
You're welcome.
We do have our next panelist, Dr. Bashar, who is in theater, busy, but is still with us. And Bashar is also contributing a lot in this webinar, and we'll learn some experience of him into this very challenging topic. Dr. Bashar, welcome in this meeting again, and thank you for joining. Our other panelist, Dr. Mokbul, has informed me that he will be slightly delayed because he has some important patients to see. So hopefully he will join us in between. Dr. Humayun Kabir should be with us soon. I had a brief talk with him very recently. We have one panelist, Dr. Asad Mushtaq from South Africa, who is a trauma surgeon there. Unfortunately, due to some emergency, he is on a flight now. He just informed me before he flown. So he got some home emergencies. So we're missing him, but we'll definitely get him once again very soon, inshallah. I don't see Professor Nirmal Kanti there yet. Hopefully he will join with us. One of our speakers today is Dr. Saklayan, who will tell us about this subclavian artery injury, its background, a brief presentation on this. Saklayan said he's busy in the cath lab, but he has managed his time to present it with a dual mode therapy, which we should enjoy. So without further spending time, I'll request Dr. Saklayan Russell to present his presentation on subclavian artery injury. Thank you, please, Saklayan, go ahead. You can start sharing the screen with us now, please. Yeah, if you please unmute yourself, Saklayan, and then start sharing the screen, please.
Okay, sir, can you hear me, please?
Yes, we can hear you now.
I think it's okay now. Let's share my screen. Sir, allow me a few seconds, please. I think it's okay now. Sir, actually need some guidance whether it is audible to you or not.
We can
Sir,
hear you.
Okay, sir. Okay, sir. Actually, subclavian artery injury very much and not so much common actually. It's a rare disease. Even I don't have any experience regarding how to deal with the subclavian artery injury, but still I will try my best to share some important part regarding subclavian artery injury. Actually, our mentor, Professor Abul Hassan Quddus sir, just a few days back, he asked me to present the topic subclavian artery injury, and he guided me that you just initiate the presentation, we'll discuss. So actually, I am expecting more discussion from today's presentations. And already before going to my presentation, let's have some focus on the anatomy of the subclavian artery. All of us know that it lies behind the clavicle, and this is mainly the protective part of subclavian artery from getting any injury from external source. And mainly the right subclavian artery arises from the brachiocephalic trunk, and left subclavian artery originates from directly from the aorticus. All of us are very familiar with this part. The subclavian artery laterally between the anterior and middle scalene muscles, and the distal part and the distal limit of the subclavian artery is the lateral border of the first ribs, where it becomes the axillary artery. Additional branches of the subclavian arteries include the internal thoracic artery, vertebral artery, costocervical trunk, thyrocervical trunk, and the dorsal scapular artery. During the development, there is some variation from the left and the right side. The left subclavian artery arises from the 7th intersegmental artery, and the right subclavian develops in segments like proximal from the 4th aorticus, medially from the dorsal aorta, and distally from the 7th intersegmental artery. These developmental differences actually make the difference in the form of injury, and there is a difference in the management protocol due to its anatomical differences. And any subclavian artery trauma requires expedient diagnosis and quick technical skills by the trauma surgeon, including definitely the vascular surgeons also. And the latest study suggests that endovascular management has a potential role in the management of these injuries. Patients with arterial subclavian axillary injuries have an estimated limb loss rate 2 to 4% to 2 to 9%, according to recent journals. Already, we have some idea that subclavian artery injury is rare but not so uncommon. It occurs less than 5% of trauma patients. The subclavian vessels are well protected behind the clavicle, already I have mentioned, and majority of the patients spare from the subclavian or proximal axillary artery injuries before arriving at the hospital. In hospital, mortality remains significant and is approximately 10% in modern reports. Study reported a mortality rate of 46% patients with blunt subclavian artery injuries arriving in shock. Isolated subclavian artery injuries have a lower mortality rate than isolated subclavian venous injuries. There is some differences between the blunt and penetrating injury, because most of the time the common etiology is blunt trauma or penetrating injury. Even sometimes we are doing injury to the subclavian artery by arterogenic procedures like venous catheter also. Blunt mechanisms are less common than penetrating. This is the first point. And second point, associated injuries also vary by mechanism. Like penetrating trauma more commonly results in the formation of a pseudoaneurysm, but in case of blunt trauma, brachial plexus injuries are more common, usually secondary to a fall on an outstretched hand. Penetrating trauma are associated with an increased mortality rate, whereas blunt trauma has a higher morbidity rate due to injury to surrounding structures. Iatrogenic injury to the subclavian artery can also occur due to failed central venous catheter placement attempt. Already have mentioned this point. The first portion of the subclavian artery lies near the internal jugular vein, carotid artery, vagus nerve, and the phrenic nerve. So injury to the proximal portion of the artery is rarely caused by blunt trauma due to its anatomical location deep within the chest cavity. But the third portion of the artery is the most accessible surgically also. Patients suffering from subclavian artery injuries can have minimal initial symptoms on presentation, like in particular for patients with a blunt trauma mechanism. Less than 25% of patients with subclavian artery injuries have hard signs of vascular trauma on physical exam. Physical exam findings that raise suspicion of subclavian artery injury include absent upper extremity pulses, brachial plexus palsy, audible breathe, supraclavicular hematoma, partial fracture, and active hemorrhage. Actually, these are the common clinical presentations of a subclavian artery injury. Low grade for the treatment or management of subclavian artery, when there is low grade intimal injuries or arterial occlusion in selected patients with no signs of limb ischemia, can be managed with observation, that is conservatively with serial CT angiogram or ultrasounds, and anticoagulation with anticoagulation or antiplatelet agents. Usually, two types of management is there: open surgical procedure and endovascular procedure. Open surgical procedure, most of the time we have to do, particularly for blunt trauma and sometimes also penetrating trauma. But skilled surgical hand and a skilled team approach is a mandatory to handle this type of open surgical procedure. Modern era is tried to focus mostly on endovascular procedure, but there is some criteria for endovascular procedure, like endovascular repair of subclavian artery injury are in injury segment less than 3 centimeter. This is the criteria. If the injury segment less than 3 centimeter and partial disruption of the arterial wall, this is one part. And second, endovascular repair is the most common for pseudoaneurysm and also commonly for left subclavian artery injuries due to its thoracic location compared to the extrathoracic location of the right subclavian artery. But there is some contraindication like vessel transection, brachial plexus compression.
Saklan, we lost your audio a little bit.
Aneurysm. Some complications are also there, like access site hematoma, pseudoaneurysm formation, stent graft stenosis, endoleak, thrombosis, and decreased cerebral blood flow due to an endovascular stent covering the vertebral artery. So I'm just at the end of my presentation. The mortality rate for subclavian artery trauma is high, as these injuries are difficult to diagnose. Second, pre-hospital protocols and trauma systems improve mortality rates from subclavian trauma could also improve. Early recognition of subclavian artery trauma is a must for early attention. As endovascular approaches continue to become more prevalent, it is important to continue to evaluate the long-term outcome of this approach. Actually, that's all from my experience, from my theoretical presentations. I hope our learned panelists are there. We are here to learn more from them. So thank you thank you, Honorable Professor Mahbub Kuddus sir. He's an excellent teacher, and he's trying to enrich our vascular knowledge by personally and also by Planetary Health Academy. So our gratitude and thanks to Planetary Health Academy also. Thank you, sir.
Thank you, Dr. Saklan. A very well presented this huge complicated topic that we exactly looked forward to see. Just an overview of this topic so we can go into depth of it. Yes, I mean, I'm very grateful to Planetary Health Academia to create this platform for us, and through this PHA, we're trying to get ourselves more educated on many vascular aspects. So I'd like to request Dr. Abdul Rahman to comment on this presentation, and if you have any question, please.
Well, it is a very, Saklani did a excellent detailed job. So I think that requires a lot more discussion about approaches of the surgical approaches, and most of us doesn't have that wealth of experience because this is a rare incidence. As you mentioned, is only 3 to 5% trauma cases comes with the subclavian injuries. So most of the vascular surgeon doesn't have that wealth of experience of dealing in the subclavian. Example, in my 45 years of practice, I have encountered 3 cases over the years, and that's very little, very few in individual experience. But we have to gain it from the collective experience, reported collective experiences, and that's needs to be discussed, and we can get a better impression how to handle this. First thing is the suspicion of subclavian artery injury should be alerted seeing the X-ray of the patients. And if you have a subclavian clavicular fracture, scapular fractures, and also hematoma in the lung apexes on the either side, or spinal fractures, those are the key suspicious lesions you see in a blunt trauma. Of course, penetrating injury is easy to assume you will have a injury depending on the patient's clinical presentations. That's what I have to say right now. Let's carry on the discussions.
Thank you very much. Thank you. So I just have one comment and maybe one question to Saklayan. The comment is, like when we see the distinction between the subclavian artery and the axillary artery, it's just a little tip for all of us who go into this territory with open approach. I mean, the fast rib border is the anatomical marker, but that we cannot see. We only see that fast rib when you do the transaxillary or supraclavicular fast rib excision for thoracic outlet syndrome. Otherwise, when we expose the subclavian, the key marker to find this point between subclavian and axillary is the pec minor, the pectoralis minor. So you just need to go at the lateral border of the pec minor where the axillary artery starts. So again, when you try to explore the axillary artery for for example, we do the XFEN bypass, just go for the pec minor, retrieve it laterally, and then you see the axillary artery. This question to Saklayan, you very rightly mentioned that if it is isolated injury of subclavian artery versus isolated injury of subclavian vein, the mortality is higher in isolated subclavian venous injury. Can you explain us, please, why is that? What do you think, why is that, Saklayan? It's true, it's true. Can you hear me, Saklayan?
Sir, sorry, sir, network problem. I'm just available, sir.
Yeah. No, though, I was saying that you very rightly say that isolated subclavian venous injury has higher mortality than isolated subclavian artery injury. Would you mind just to explain it to our audience? Why is that, or why do you think that is happening? Yeah, I think there is a network problem. I mean, correct me, Amit Bhai, if I'm wrong. So the main reason is we always see that the venous injury or venous bleeding is difficult to control. That's one thing, because it's not a solid structure like arterial wall. It's a very friable wall, and the arterial bleed pulsates, so you can get into that area. The venous bleed just bled everywhere. The main reason is that the venous injuries are most of the time associated with other injuries in the chest, like the cardiac or the severe pulmonary injury. So that's why their mortality is a bit high. So also you mentioned, Saklayan, that a brachial plexus hematoma is a contraindication for endovascular treatment. which is probably not the case. You can still treat it endovascularly, provided the other criteria in the artery injury is maintained for endovascular treatment. But a separate setting of evacuating that hematoma may be indicated depending on the extent of the brachial plexus injury. I'll just go to Dr. Bashar, who is our other panelist present at this moment. If you want to make a little comment or question, Bashar. Bashar, can you hear me? Okay, so just in respect to Saklan's presentation,
can you hear me, sir?
Yeah, yeah. So I was asking if you want to make a little comment or any question on Saklan's
Sir, I
presentation.
think I will get to you in the session of final discussion. I think we can carry on. And
Fine.
of course, I
Fine.
have to say, but I think we can
No,
do it.
that's
at the end.
fine. That's fine. In that case, if I'm allowed to do a little presentation of myself, and then at the end, we're going to discuss a bit more about it. Okay, so.
Exactly. That's how I'm thinking. Yes, sir. Okay.
Thank you. Okay. So I hope you can see my slides. Abid, দেখা যাচ্ছে আমার slide?
Yes, yes, yes.
Okay, so I'm going to talk a little bit about this subclavian artery injury, and then we're going to discuss a case very elaborately. So we can criticize or make comment or try to improve where we need to improve. So as I said, and as the topic is, the subclavian artery injury is a very complicated territory in vascular surgery. And as we all agreed that we don't see it very commonly, but when we see it, it's a real challenge. So we try to get a full grip on it. So subclavian artery injury, which we'll keep telling in abbreviation SAI, it results in significant mortality and morbidity, regardless the mechanism of injury. Subclavian and proximal axillary artery injuries are rare and is very difficult to manage, that we all agree. And traumatic subclavian injury is rare but often fatal. So that we need to remember that this is a life-taking injury. It can be fatal if we don't act on it properly or quickly. So what is the overall outcome of this subclavian artery injury? Now, of course, it varies between areas and areas. I mean, it will be different in Virginia or in Texas or in Manchester. Or, if we compare some part in Bangladesh, or we compare some part where there is no immediate access of emergency service facilities. So overall, there was a broad study done. It shows that many of the victims of subclavian artery injuries cannot reach the hospital because if it causes active bleeding, it's a torrential bleed and patient can die before they reach hospital. And including some underdeveloped areas, the mortality before reaching the hospital could be as high as 61%. Those who can reach hospital and have operation intervention, be it open or endovascular, their mortality was still high, between 15.5%. So overall, if we count that those who cannot reach and who can reach, the mortality is overall very high. So it's something which is not very pleasant to deal with. Now, how can we intervene it? As Saklan says, we can do the open surgical repair, we can do the endovascular repair, and nowadays we can do some hybrid repair, which is a combination of open and endovascular. Now, in terms of endovascular repair of subclavian artery injury, it represents an attractive alternating to the traditional open surgical approach, which was the landmark before for the treatment of traumatic injuries of the subclavian artery. The endovascular repair was identified as the only modifiable predictor of reduced mortality in patients with penetrating injury. So if we think about mortality, overall mortality of penetrating injuries, and we see that what are the modifiable factors. One of the important modifiable factor is the endovascular repair. If we can treat it endovascularly, we can reduce the mortality. Endovascular repair are used most often for the pseudoaneurysm or a contained injury or an injury which didn't cause non-avulsion or non-total disruption. So those are the areas where we like to do it, like to treat it endovascularly. In terms of open repair, so this is the key point, because we, the vascular surgeon, need to be prepared for everything. We need to be prepared that if we need to treat it endovascularly, so we have the capability to treat it endovascularly, but we need to remember many times it will not allow us to treat it endovascularly. So that means only option left behind is to do an open repair. So we need to get ourselves more used to and more oriented and more practiced with this open repair. So if a patient is unstable, we're not going to get the endovascular setting ready and have our time to take the patient, get the kits ready and do it. So we have to immediately take the patient to theater and open it. So that's the only way to save a life. If somebody is bleeding actively, we can see the jet is coming, or we can see the patient is dropping blood pressure like anything, losing hemoglobin. That patient need to go to theater for open repair. And if the vessel laceration or transection is more than 50%. So if you see on some image that yes, there is a near partial transection or is a big laceration, you can't see the other wall properly and you think it's more than 50%, you cannot put a stent in that artery. You have to fix it with open surgical repair. So we need to know how to fix a subclavian artery injury in an open way. Now, in operative approach, so it's slightly different between the right subclavian artery injury and the left subclavian artery injury. So most of the right subclavian artery injury, if we need to do the open repair, we need to do a midline sternotomy, a median sternotomy, especially if it involves the brachiocephalic trunk or the bifurcation of the brachiocephalic trunk. So you have to open the chest, get a proximal control, then get the distal control and repair it. So many in this situation, we may have to ask help from our cardiac surgeon to help us. And that should not be delayed or should not be hesitated. In terms of the left subclavian injury, if it is a very proximal injury, then again we need to open the chest. And some people tried the anterolateral thoracotomy, or we can do a sternotomy with extension of the top incision on the left subclavicular area, like an open book thoracotomy incision, and then get the control. Many of the patients with subclavial artery injury will need excision of part of the clavicle, and we should not hesitate to do that. We can do a claviculonectomy if it is needed. And it's just one thing we need to be all focusing very importantly. Any subclavian artery injury which we're trying to fix in an open way, it should be always a subclavicular incision. With supraclavicular incision, you cannot repair a subclavian artery injury. It will be hugely difficult. Patient will bleed and lose. So no supraclavicular incision, please go subclavicular. Now, what is the overall outcome of a subclavian artery injury repair? So patients who reached the emergency room with measurable vital sign that their blood pressure is still there and the pulse is not very tacky, they have a good chance to survive. The subclavian vascular repair, most of the time, will achieve restoration of circulation. Saklan says there are a few history of limb loss. That only happen if the circulation cannot be restored properly. If you can restore the circulation, the limb loss risk is very minimum. And the principal morbidity is associated with the brachial plexus injury and the other injuries like lung injuries or thoracic injuries, injury of other thoracic organs. Now, we'll see a case which was very challenging, and I had to deal with this very recently, of a challenging case of left subclavian artery injury. So this was a 87-year-old gentleman, quite old gentleman, who was a bit frail as well. He suffered from atrial fibrillation and he was on warfarin. So he had his initial fall in February this year, so just about not 2 months even, it was mid-February. And he sustained a fracture of the left clavicle. And he fell again after a few days, and then he sustained a bit of a polytrauma. And he was immediately taken to a hospital where they do not have any vascular surgery covered. And they did appropriate investigations they contacted us. The patient was right-handed, so is the right hand dominant, and they could feel a left radial palpable pulse. So as Abid Bhai was saying, that if somebody has left clavicular fracture or other multiple trauma in that area, you need to have a high index of suspicion, and you need to rule it out with proper investigation. And one of the proper investigation is a CT angiogram, which you can do quickly and immediately. So these are the multiple injuries. The patient sustained a fracture of the clavicle, as we can see. And to complicate our life, this patient also sustained a fracture of the C1. And he had fracture left 4th, 5th, and 6th ribs. So this is a very, very challenging condition. I mean, the subclavian artery injury in itself is a challenging problem. Now, patient has a cervical fracture. And we know that how much care we need to take on the movement of the neck. Forget about the rib fracture. So, what do we do with him? So, it's a nightmare, basically. So we did that CT angio. And as you can see on the CT angio, this is the injury of the subclavian artery. You see the disruption here. There is no continuity here. We took the next film, and you can see the jet of blood going into this pseudoaneurysm sac. Then this is the rest of the artery, which was reasonably okay. And you can see this little blush here where the blood was getting. Now, we need to make a treatment plan, and it's not easy to make a plan on this type of patient. So we need to think few things. This is a frail patient. He's not a very suitable patient for massive, adventurous surgery. On top, he had a C1 injury, and luckily it didn't damage the spinal cord. But it's a potential source of having a spinal cord if we don't look after the neck properly. So obviously he was on a hard collar. Now, if we need to do open repair, we have to give him general anesthesia. And during intubation, the neck movement will be there, and he'll have high risk of spinal cord injury. At the same time, if we do open operation, we need to move the neck to some extent, and that increases the risk of spinal cord injury. So we plan to do a treatment of endovascular stenting of this artery under local anesthesia to avoid any intubation. Now, there are, of course, drawbacks, and we need to consider some point of caution. So the plan was we will go through the right common femoral artery, which will allow us to get proximal control if we need to. Because if we come from the left brachial artery, we can't go proximally if we cannot cross the injury. And if we fail to cannulate it for the aorta, meaning the right common femoral access, then we have to access it through the left brachial artery, and hopefully we can cannulate. Now, also looking at that CT, it cannot reassure that you will be able to cannulate the artery properly, mean cross the injured part, because if it is quite floppy in that area with significant disruption and lot of intimal injury, the wear will not go through. And I have seen that many times, that you cannot simply cross the injury. Or the patient may start sudden torrential bleeding because this pseudoaneurysm can rupture. So those were the points we need to think of. And the important part on management is you always need to think these possibilities and then have a backup plan, because if it happens, then we don't have any time to think about it and start planning. So the backup plan, that if endo intervention fails or the pseudoaneurysm ruptures, what could we do? So the plan was that we need to do a careful intubation according to cervical spine fracture protocol, where there is minimum movement and expert anesthetists can sometimes do it without causing much problem, and then try to achieve a proximal control with a balloon. And then, I was planning to open it through the left subclavicular incision. And the plan was also to excise the segment of a clavicle immediately and then repair the injury or put an interposition graft. So that was the treatment plan, backup plan. Then we started this endo intervention. So the key important thing is to have a long sheath which can come up to here. So you cannulate the aorta through the right common femoral artery percutaneous puncture, and we can see this subclavian artery. We can see this bleeding, and also this is quite proximal. So surgically is very difficult area to control. So luckily we managed to cannulate it properly. We managed to cross the injured lesion, and which make our life a little bit relaxed at that point. Then the important thing, as you can see, that's the end of the sheath. So it's a very long sheath. So we have to bring the sheath all the way here to have proper cannulation and proper control. So that was successfully done. And you can see the end of the sheath here and this wire and catheter going through there. So we managed to put a stent. You can see this part of the stent here, which we are inflating with a balloon. So we have a 10 by 10 Gore Viavan stent, and then we use a 9 by 8 Amanda balloon to inflate the stent. So you can see the stent here. This is the one end, and then we just inflate it with the balloon. And this is like a completion picture after the stenting, good flow, no leak, the pseudoaneurysm is gone. And this is the picture of the arm. It goes all the way down below the elbow, so showing the good perfusion. So to conclude, luckily this patient was treated successfully, and I think the appropriate planning is very important. And as I said, the backup plan is of crucial importance. So a high index of suspicion, a rapid transportation, aggressive resuscitation, and proper surgical exposure and repair or proper endovascular intervention are essential for the successful management of these rare vascular injuries of subclavian arteries. Thank you very much. So before I go to our discussion, I'd just like to inform everybody that there is going to be a live conference, Live 2024, which is Leading Innovative Vascular Education. It's a very good one. I have been there previously a few times in Rhodes, Greece, a nice area between May 16 and 18. And I'm quite privileged and happy to say that I'm giving 3 presentations in that conference. So, I was going to call Abid Bhai yesterday that if you like to join me, and requesting everybody else who can join there. And I'll be happy if I get some of our person when I present this 3 topics. Thank you very much once again.
Nice place to visit.
It is indeed, it is indeed. So what I'll do, I'll stop sharing now and we'll open the discussion with Abid Bhai, please. Thank you.
Thank you very much. It's a good, very good presentation, case management. And I just want to bring up this endovascular thing. In preparation for these discussions, I reviewed some literatures, and I came across a American College Trauma Quality Registry. One of the surgeons from Memphis presented, went back retrospectively from 2015 to 2018, and he found 753 cases of subclavian injuries from the registry, and stratified the blunt trauma versus penetrative trauma and the surgical managements versus endovascular managements. Yeah. And that's, as I said, nobody has a exclusive experience of subclavian artery. With this assessment, I think we'd have a better understanding what's the proper treatment nowadays. As it used to be, used to be surgical with the endovascular advent and many technology and techniques available. It is more trending towards the endovascular repair. Obviously, there are some definite contraindications. We cannot manage it. As you said, it's a hypotensive crashing. You don't have time to do the endovascular. The study said 58% of the cases were managed endovascularly. That's sort of astonishing to me from my own personal experience. 58% of the cases managed endovascular is pretty high. And the conclusion also that the endovascular management has reduced the mortality in penetrating injuries by 50% and reduced the morbidity by threefold, which is quite remarkable. It didn't make any difference in the blunt injuries. It's equal morbidity and mortality. So that really tells that endovascular is a very good options when the technology and the equipment is available. If it's not available, that question is out of the reach. The other part, Saklan said 3 centimeter length of endovascular approach. That was 2007 recommendation when the endograft availability was only 5 centimeter length. Nowadays, you have a longer covered stent. So I don't think that should be absolute. That's my personal. I would like to hear from you and others. My personal theory would be 3 centimeter is not really, it's a relative contraindication, but when you have a stent, longer stents available, that shouldn't be absolutely adhere to it. So that's the conclusion. I think the endovascular route is a growing approach or better approach to a certain extent, especially for the penetrating injuries.
No, I absolutely agree with Bhai. Yeah. So, that was the other point I was going to raise with Saklan, that this 3 centimeter length is not a limited one, because we do longer segment of treatment on subclavian artery injury if it is suitable for endovascular repair. So that's the important thing. Now, this is true, yeah, and as I mentioned in my presentation as well, that this endovascular treatment is the only modifiable predictor of having improved outcome, which is very true. Dr. Bashar, if you have any comment and share some of your experience at this situation now, please.
Thank you very much, sir. Once again, assalamu alaikum and good evening from Bangladesh. I think I was actually moving in the midst of this whole webinar, because I started when I was in my chamber, then I walked back to my home, and then did things. Okay, so I was all along with you, so I followed the presentation. I mean, it was really nice to see that case presented by Mahbub sir. I think, I mean, we at NICVD especially, because that's the place where we have the majority of experiences in any injury situation, not only subclavian. But I mean, I also I'm taking the words of Abid sir and all of you that have given opinions. Yes, subclavian injury is of course rare, subclavian axillary, but people who have worked at NICVD, I think Mokbul sir would agree with me that, I mean, maybe this is one place where you can really build up on your experiences with this particular type of injury, because no, I mean, I've been here for 15 years, say then, and I can clearly recollect the cases that we have come across over this long period of time. Mokbul sir also will agree with me that he has also come across significant number of cases, subclavian axillary injury cases, and it's not very uncommon. I mean, my NICVD colleagues will agree with me. It's not very uncommon, because every now and then we have these cases, and accompanying phenomenon will be the brachial plexus injury. So this is actually a pretty common picture in ICU. Moinul, I'm not sure if he's here or not, because Moinul was with me in the last case, and Dr. Shantanu and Dr. The little Sojul that we have, Mahmoud Hassan Sojul, our resident registrar. I'll just reflect a little bit on the last case that we did. Of course, it's way different from what you presented, Mahmoud sir. Because we have to do things differently, and that comes from the decisions, and the strategy comes from the availability of resources or the lack of it. You know that. So endovascular very rarely features or comes to our mind as an option. We know that the things are there. Now 58% of the cases are being managed according to that study which sir mentioned. That's a very nice figure to have, and very encouraging as well, because we know that is the direction we should be heading, because to reduce mortality and also to reduce the number of, reduce the extreme sort of torture, mental torture on us as surgeons, because when these patients show up, we really take a lot of, tension and the mental anxiety dealing with them, because we have to really do a lot of negative counseling to the patient body. This is not a good scenario to have, and we might lose the patient. So when we talk about the situation like that to the patient body, so the hearts are broken from both sides. So, so this case, last case, was politically and I should say administratively sensitive case, because that was referred from the border area of Bangladesh, somewhere bordering Myanmar or India, some part of India. There was a lot of confusion because the SIs, the police got involved, and our director, sir, he kept calling me and he kept whispering at me that, okay, this is state secret, so you have to really do it in that kind of a way, because the injury to was caused by bullet injury, pellet. And this is one common modality of injury. I think my colleagues will agree with me at NICVD that bullet injury, projectile injury is one. And the other thing is, of course, the penetrating injury in the form of, say, tetanus and all those things. We have seen a lot of tetanus coming in, and patients have been referred with tetanus in situ. They could not be removed. So we at NICVD did that with the help of the thoracic surgeons, all those people. So, I can clearly recollect these cases. So the last one was again a C positive case, hepatitis C virus positive case. That made the situation even worse. So we managed to do a CT angiogram, and then we found that pseudo aneurysm, because the case was a few days old, I think a week old, when he was referred to NICVD by the time we got him. And then CT angiogram revealed that pseudo aneurysm sitting at the junction of the subclavian axillary. I have my photo, but I thought Shantanu or Dr. Moinul would be presenting. So I thought they would bring it up, but I have it still now with me at WhatsApp. So the thing is, we took a few days getting to the management plan, because C is not generally addressed at an NICVD, because if you do a C at EVOT, emergency vascular operation theater, then the operating room has to be shut down for a while. So by that way, other emergency cases are deprived. So we try our best not to address hepatitis C or B virus cases at the emergency. But this particular case could not be, refused, because it was a straight emergency sort of, because the calls were coming from police and all other important places. So we had to go in. I was supervising, and I'm really grateful to our Sajol and Moinul. He came in because he took a very daring approach, Dr. Moinul, because sometimes, we take things on our own hand. Ideal approach would be taking proximal control or doing something from the proximal, a balloon inflation or something like that. We have been trying, but because we tried to make the approach like that, but it was not working that way. Then because the approach was, by that time, there was a lot of adhesions and all those things. So, and the pseudo was pretty big. So what we did is, we were thinking what to do. Then we are prepared for the clidotomy and even for the sternotomy, because we know that the approach to get to the proximal end, something really need to be done in terms of mobilization or creating a space. So finally, clidotomy was done, and that ensured a little bit of space. And then Moinul came in, and without even taking a proximal, because we know that the artery was not transected. It was a partial wall injury. So we had the continuity. So we actually we dared to go in like that without even being able to take a proximal control, proper proximal control. Thrombus was there. So we just approached and we got to the proximal end of the artery through digital control. Sort of pressure on the proximal vessel. It was bleeding, but from proximal and distally, we managed to, the distal control was taken, and then the proximal, we pressed against the artery to ensure hemostasis during the operation. Of course, the blood was ready and it was being transfused. And luckily, that worked. And we found that, okay, after clearing the area of all those thrombus and debris and everything, we found that it was nothing but a small linear tear on the entry wall of the subclavian artery. That was very easy. So we are then considering what to do, either to repair or to ligate. So that was another decision. So finally, we went for ligation, considering the reality that, okay, this is a positive case and an infected area of 1 week old. We saw the evidence of infection as well. So we thought, okay, let's ligate, because after clamping the artery, we saw the collaterals were already developed and the saturation was good, and the saturation not dropping that much. So we counseled the party accordingly that if we repaired, and if this was going to re-bleed or secondary anastomotic failure or something like that, nobody's going to address it, because we did it once and nobody's going to go in for a second time. So we counseled the party accordingly, and we made our own decisions as well. So we ligated, and we came out well, and we took out the pillet as well, because that had to be preserved as an evidence that we did the surgery. And then the patient actually recovered very well. Then we could refer him, and without any further, damage to the limb, because the neurological damage has been done. That will be taken care of. The neurosurgeon and neurologists, they're also involved. They came in from these neighboring hospitals, and they also talked to the party. And we thought that the operation will be done by a team comprising vascular surgeons and neurosurgeons as well, because we considered one operation. And if there was any tear in or any injury, significant injury, the brachial plexus cords or things like that, possibly, we thought that they would address it the same sitting. They visited and they talked to the party, talked to us as well. And they gave their opinion that, okay, no, this is not our time to do it. Let the vascular port be fixed first, and then we'll take it up in a second session. So that's how the party was convinced, and we did our part and came out like that. Our part was done. The ischemia did not aggravate, and the limb was salvaged from a vascular point of view. And functionally, the limb was bad actually, because the sensory and motor functions were already compromised. So this is one latest experience that we had. I remember having this sort of experience from time to time. Every other month, actually, we'll be having a case like this. So if we accumulate, we probably can go through the records that we have at the emergency vascular operation theater. I think we have a significant number of patients that we can fall on. And we can't possibly report on that as well, because we did not do any endovascular, not a single one. So I think this can be another, different type of experience to report on that, okay. And I don't remember losing a patient either. Maybe, okay, the limb was, compromised maybe, but we did not lose a patient, doing subclavian by surgical means. Thanks.
Thank you very much, Bashar. Thank you for sharing your experience. And it's good to know that you do come across a number of patients with this situation, and that helps to get our vascular surgeons better trained and equipped. And yes, I fully agree that many times the open approach is the only approach, especially if you don't have your endovascular setting ready by the side. So is Professor Niaz still with us? Can you hear me, Niaz bhai? So probably not.
Just Assalamu alaikum.
Walaikum salam, yeah.
I just came from the Ramadan Umrah. Just my voice down. I cannot, just last 2 days, just because of my voice problem is shut down.
Okay.
So
No, it's fine.
Yes, you are working hard for us. And are you in Bangladesh or from UK?
I'm in UK now, yeah.
When you have a plan to come to visit Bangladesh next?
Inshallah in June, I hope. Yeah.
If you come in early June, then we can, I want to take you to Sylhet, Sylhet Heart Foundation. Next time, Professor Abid also going there. So it will be appreciated if you have managed a time to go to Sylhet.
Inshallah, we'll try our best. Yeah. No, thank you, and have your voice recovered very soon, hopefully.
That's why
Yeah. Is there anyone else in the audience like to ask something? Dr. Jubair, do you have any question, any comment?
Thank you, sir, for giving me the opportunity to put something. So I had an experience actually for subclavian vein injury when I was in the post-graduation course, and it was 2014 at NICBD. And the surgery led by J. Mogulusen, sir, and we managed the cases by median sternotomy with the help of cardiac surgeon, and it was really a nightmare. The patient came with a penetrating injury and managed to stop the bleeding. And yes, subclavian vein injury, I think more difficult to manage than the arterial injury. And we need to transfuse a lot of blood. So far, I remember around 6 to 8 packs. But finally, we managed to save the patient. That is my only experience. Thank you so much, sir.
That's very good. Yeah. Yes, I mean, we do have this dire experience many times. I have one patient, I remember that he was falling from a height and he managed to hold the corner of that cornice or ceiling just to, hang him from there. And he was holding it for a good few hours before the emergency people can come and rescue him. And with this pull of this hand, he has sustained a traction injury of the left distal subclavian artery, and it was sort of avulsion injury. And we actually failed to cannulate it through the left brachial cut down even. And then I had to open that and put an interposition graft. So we have to have this option of open and endovascular, depending which one is appropriate of that particular patient. So if there is no question, yes, please, Abid Bhai.
I do have a comment, and the Bashar's discussions, and I think his patients group, as I understand, they usually come delayed. They are already stratified. Their prognosis already predicted will be better than patients who report immediately.
Yeah, they survived their worst time. Yeah.
Yeah, they survived their worst time, critical time. So that's one comment. And the other comment about the venous injuries, I think we should keep in mind venous injury is definitely worse, but nowadays a venous injury could be repaired as well as with the endovascular approach. So that we should keep in mind. Nowadays venous stents, covered stents available, so that should be considered instead of. In fact, that should be primary consideration if it's doable, before you go to surgery, because surgery is devastating.
It is, yeah, it is. Yeah. So we can see Dr. Mokbul on our screen now. Mokbul, thank you for joining, even if you are at the end of the meeting now. So we did see a few nice cases, discussed a few things. I think you have missed it today, and we missed you. So I don't know, have you heard anything so far from the discussion, Mokbul?
We can hear you.
Are you unmuted, Mokbul? Yeah. There is a bit of a microphone issue, I think, which I had initially. So Mokbul, let us know when you are connected better. We just will get a few words from you. So yes, I mean, the other thing, Abid Bhai, during my work in South Africa, which is full of trauma, I managed to came across a number of subclavian artery injury, including all other injuries. Even I remember, one of the first trauma on call was a subclavian artery injury, actually.
Wow.
So, so that was not the nicest experience. But even in UK, I think the UK, most of the subclavian artery injury I found, there quite a few with the orthopedic injury, like a shoulder injury, bad shoulder dislocation, bad shoulder fracture, with concomitant subclavian artery injury. And also that, the traction injury I mentioned, and the road traffic accidents, I have seen few, and like this few stabbing and gunshot. Actually, I've seen few gunshot in South Africa, but not in UK. So there is a wide variety of etiological factors. And I mean, it's a contained space. So if the patient can
Right.
overcome the initial few hours, from dying, then come to hospital, it's manageable. That is my feeling. And with endovascular, it's more helpful now.
Yeah, and the surgical approach, and I think clavicular approach is still a good approach.
Yeah.
And the vascular surgeon in Bangladesh has more experience doing sternotomy than the vascular surgeon outside the country. So they shouldn't be hesitating. I always say, so you guys should take up that portion, sternotomy, and repair the great vessels as often as it's seen. I'm not sure why they're gun shy to undertake that procedures.
Yeah, no, which
We
is
do
true.
it from
And
time to time because we have this sternotomy set up at the emergency vascular OT as well. We have to arrange it, and we have to make a prior plan, actually. But it's not to say that we don't do it, but again, it's not very common for us to do it because sternotomy, SOR, and all those things are there at the emergency vascular OT at an SCVD at least. So, yeah, I mean, there are people who can do it from time to time.
Well, in that case, then the subclavian injury should have a routine sternotomy incision extending up or left or right. Depending where the injury is, if it is distal, then you can obviously go subclavian incision. But if your injury is first and second part of the subclavian artery, of course, the right is always a sternotomy, but on the left as well, a sternotomy and extending to the left is more accessible than just a supraclavicular incision.
Yes, especially if it is a proximal injury.
Yes.
I mean, with that sternotomy, if I may be allowed to share one of my experience, please.
Sure.
So that was in South Africa. So basically, a patient had a single step wound in the left second intercostal space. And he came to our resuscitation, and as soon as he was entered into resuscitation, he started gasping. So he was pretty much dying. So I just called in and went into that resuscitation room, and I saw his gasping, and one of the doctor was intubating him because he will lose his breathing very soon. So my comment was just put the tube in, push him to theater. I'm going to get changed, and I'm getting in theater. So I just ran, get changed. I was in my normal clothes, and then I was running to the theater, and one of the anesthetic register was waving me not to run. He said, don't run, don't run. Patient arrested. So I went there and I saw the flat ECG, and they were giving the chest compression. So I don't know if it was probably adrenaline rush or some, excitement. So the nurse was having her trolley ready, and I just took some gloves without washing and changing. I took the knife from the trolley without any paint on the chest, any antiseptic, anything. I just make an incision on the chest, sternotomy. And there was no time to connect the power saw. So I just took a chisel and hammer, and I opened the sternum. I saw the bleeding from the pulmonary trunk. And I just put a Shatinsky into that and started giving internal cardiac masses. And after a minute, we started seeing some ECG trace. And then, when he had his rhythm back, so we said, fine, we're going to do a full preparation now. And so I scrubbed a good antiseptic betadine preparation, drap and everything. And that wound was controlled, so it was not difficult to close it with some primary closer. And then, antibiotic cover with chest. And I was delighted to see that patient was extubated next morning and was talking. So I will never forget that experience of mine. That was something.
That's something to do when you're young.
How long
So-
did it take for you to go in and put that clamp? I mean, from the time of that the ECG became flat, and then
So from the time I saw him in research, I said just push him to theater, and I started running to the change room. So probably 7-8 minutes maximum by the time I went.
that's extraordinary. I think that guy really hung on for 7-8 minutes.
The only thing I thought, because if I wanted to get myself a scrub and get little betadine on the chest, and then
No question. There's no
so
question.
I just grabbed the knife, and I didn't tell the nurse anything, and I moved, just make a cut on a patient,
And you're
dirty
absolutely right
skin and
about
everything.
that.
So
No question.
I mean, that was probably adrenaline at that time, and as Abid Bhai says, that was the age.
That's a different time. Congratulations. This is huge.
When I was young, I had similar stories. I guess that was different. I was a third year in practice. I was taking trauma call. All of a sudden, I get a call. There's a penetrating injury to the left chest. Come on in. I came in I see a cardiac tamponade. I said, don't wait, let's go. In 15 minutes, we're in the opera. This is a cardiac surgery domain. I said, nothing doing. Let's go in the operating room, call the cardiac surgeons, and open the chest and repair it. By the time cardiac surgeons came in, I repaired the left ventricle, and there was a big cry in the hospital. Why did you take the patients to the surgery? Say, patient survived, right? So, you stop.
So what if the patient would not make it then? I mean,
he's a young 20 years old guy there's no reason to not make it. I mean,
no, but how did you open the chest, Abid Bhai?
Left chest. I didn't do this.
Anterolateral.
Left ventricular injuries.
Anterolateral, yeah.
Yeah, anterolateral.
Yeah. No, I mean, I think, we're getting nostalgic now. So in South Africa, I had this opportunity to do a lot of stab heart and gunshot heart. And I have done actually 32 sternotomies there. And the first... Fast stab heart, Abid Bhai, I remember I was seeing a general surgical patient in A&E with abdominal pain. And suddenly a young man like yours, like 24, 26, because South Africa have a lot of stabbings and gunshot. So he was rushed into theater, and he had a stabbing on the chest, anterior chest, around 4th, 5th space. And he was dying basically, and we immediately knew that it was a stab heart into the heart. So in that, because he was in emergency room, so I immediately did an anterolateral thoracotomy and put my finger into that hole. It was a hole in the left ventricle. And there was an anesthetist who intubated, and then we pushed the patient all the way from A&E through the corridor into the theater, my hand being in his heart and the finger. And then it went, I was still holding I holding my finger, Bashar, and then other people do the scrubbing and everything. Then, I extend that wound, put that phenosheetal, and then, repair that hole, and then, clean and everything. And so he bled a little bit because my finger was not controlling, and then gave blood and everything. So I remember one interesting thing. I was sweating, and we finished. The patient was stable. Then we went to the coffee room, and that anesthetist was so calm and quiet, so cool. Then I asked him that, how come you remain so cool when this patient was bleeding and stab heart and everything? And he told me one thing, which I actually thought is very important. He said that, look, the patient is bleeding. It is his problem. It's not my problem. So why should I get puzzled? It's his problem. It's not my problem. What can I do? So I think it looks very sarcastic, but it's true that keep your brain cool in this situation, because what can you do, if somebody is bleeding like this,
But he's not the surgeon, he's the anesthesia.
They never have to get into the business like that.
That was his advantage.
Ask him to do it once. He will say differently,
So I said that I could do the same thing, that, he's bleeding, it's not my problem. Why I should be puzzled? So yeah, I have his picture, the couple of days time, he was just showing his finger with the wound in the chest.
That's
Yeah.
great.
So those are good experiences to
Oh,
have.
yeah,
Great.
that's
But one thing, can you hear us? Hear me?
Yeah, Mokbul,
Yes.
please do tell us something. Tell us your exciting
So I missed
memory
to
as well.
how I can tell you something about this matter. But one thing at the last, the scenarios which you are telling about, the last scenario he is telling about the anterolateral thoracotomy was done in the emergency room or where? And pressing
in
the
the-
artery you are taking.
In the emergency room.
In the emergency room.
Oh, there is facility for anterolateral thoracotomy. In
No,
the
you don't need
Oh,
anything. You just need a blade. You need a scalpel blade. You don't need anything.
Just
It was
open
no
it with your
routine
finger.
or formal anterolateral thoracotomy. It's pretty
As
informal.
they
you know?
as they say, put your dike in there. Dike means your
Yeah.
finger.
Like that.
So basically,
Just like
Mokbul, you go into in between the two ribs, and we always know that we have to avoid the lower border of the upper rib.
Yeah.
And then, just put your finger to stress the rib and muscles, and then put the finger into the heart hole, because you can see that.
Yeah, it can be done in the
I
battlefield.
mean,
as well.
having said that, luckily it happened the way it was saving him. But it may not happen when I try to
All the
inject
time,
it
yes.
once
You
more.
may not be able to find the hole in the first
You
place.
may not be able to find the hole, So luckily the hole was there, which I can put the finger
Yeah,
in.
Allah decided that the finger will be yours.
And
Put in the right place.
lecture. One thing, there patients, most of the in Bangladesh, most of the patients subclavian artery injury, Bashar is here. Usually they rush to NICU most of the time.
Yeah.
And we have got exposure with stenotomy, mostly right subclavian artery, stenotomy
And
with
pledotomy also.
neck incision. Right. And
Pledo-
left side
pledotomy.
mostly left neck incision. But when there is proximal subclavian artery, question of thoracotomy definitely. But one thing, now there is so-called the trauma surgeon. They are accustomed with head to toe trauma. That is the one trauma surgeon operates the head as well as the neck, vascular, thoracic. That is the all trauma part. Question is, such a subclavian artery or cardiac injury, every sort of facility you are telling that, but without any CT scan or CT angiogram, should we proceed the patients or this delay can create complication regarding life of a problem? The question, should we go for any CT scan or we'll proceed blindly? Or we'll do as per patient's condition?
Yeah, I think the answer is as per patient's
As per
condition.
patient's condition, yes.
Because ideally we like to know where is the injury. So a CT angiogram is essential and helpful. But for example, in NICBD, there is a patient wheeled on a trolley who is bleeding, and people are just pressing with the towel and everything, and the patient's blood pressure, systolic pressure is 40 or 50. We cannot take the patient to CT scan. The patient will die on the CT table. So patient's only destination is a OR in the operating room. And we need to just do it, depending where we think the injury is. If it is proximal, open the chest and, extend it on that side, proximal control. If it is in the slightly lateral, just go with the big subclavicular opening and just, as the Bashar was saying about that hepatitis C, you're right, sometimes we cannot achieve the proximal control and we just control with finger. But what I would do, and probably Abid will agree, that you control the finger, you get some proximal control, then ask somebody to replace your finger with their, or just take a little pledget with a big artery forceps to press there, and then start dissecting the proximal part just to get a clamp there. That makes a huge difference, because God forbid, if he starts bleeding from the proximal without a proximal control, you don't have even 1 full minute to save the patient.
Of course. That's the
Other options, if you have the finger and get one of the balloon, and while you have the finger there, let the balloon go and partially inflate it and watch it, see how far you can inflate and control the bleeding. Instead of, then you have the whole gamut to dissect around the artery. That's another option. I don't know whether you guys ever tried that.
Potentially, but I mean that part when it's bleeding and that area is quite messy, and we just barely able to put that finger and achieve some sort of hemostasis, not complete. The field is still very bloody. So thinking of a balloon going in and having it inflated, I mean, didn't work that well.
No, I'm just giving you the option.
Yeah.
Obviously, we are not there. How messy it is, it depends on how quickly you can get around.
Yes.
And finger control is always available and is doable.
Yes.
And as Professor Kudus said, and you have somebody else hold it,
Yes.
we realize that, and there, that gives
Absolutely.
you out of your way. You can dissect it, and that's very good technique.
Absolutely.
And another tip I like to give, I don't know if you have experience of that, Abid Bhai or Maqbul or Bashar. Like we see sometimes this bleeding, and it's difficult to get the control because you don't see the artery, especially in the iliac vein or the iliac artery when we do the aneurysm and things. And it could be in the subclavian. One technique is to, you know, that Charney's retractor, the Charney.
Right. Push it down.
Yeah. So just push down the Charney into that area. It's such a good control. And then you can just dissect around it and get control. So that is something is always helpful. Just put a Charney into that. The Charney is the one, you know, it's like a Langenbeck, but instead the flat Langenbeck thing, it has two separate legs.
Yes. Yeah.
Thank you, sir.
That is a good technique. It
That
really
is a
helps
good technique.
me
And
few
sometimes
times.
it helps
Yeah.
pelvic bleeding and everything, even in the neck. Even
Thank you, sir.
The device is missed.
Charney's retractor.
Do you have that retractor, Bashar?
No, sir.
We're not accustomed with it.
No, sir.
I'll send you a picture, Maqbul.
Yes,
I'll
sir,
send you a picture,
Please,
and
please.
then
Thank you.
you can try to get. It's like a Langenbeck. It's a very, very cheap instrument. It's like a Langenbeck, but you know it's so helpful for bleeding control.
Okay,
Abid Bhai, you did it, isn't it? Abid Bhai?
Yes,
You
yes.
referred to it.
And the
Charney
iliacs
did it.
I've used a couple times. And same thing, I don't know whether you guys have the omni retractor. They have a similar shape. You can put the omni retractor, push it down till you control and fix it there. Your hand is free then. That's also another way to accomplish proximal control.
Different techniques.
Yeah, MSc got omni retractor.
Yeah.
So Maqbul, basically, you know, I have shown a case where it was a pseudoaneurysm from a subclavian artery injury, quite proximal. And we managed to put a covered stent there eventually. But the complicated thing was patient also had a C1 fracture. So if somebody has a C1 fracture, you know, to give anesthesia, intubation, doing some surgery with neck movement, we're probably risking a full, quadriplegia or paraplegia at this point. So luckily it did work well. But another patient where I tried to put this stent, I couldn't cannulate the artery. It was almost disrupted. So then have to go in and fix a surgical interposition graft. And Saklan gave us an overview of the subclavian artery injury. Bashar shared his experience. I'm sure you do have a lot of experience with the subclavian artery injury. So I think the take-home point from today's meeting is all of us need to be, all of us who are doing vascular surgery need to have the experience and exposure of open repair of this problem. Otherwise, many times we think we'll repair with the stenting, which is very, very helpful, as Abid Bhai said. And I showed in my presentation that only modifiable factor which can improve the outcome is endovascular if you can treat it endovascularly. But there are so many patients, you don't have even chance to think about endovascular, you need to go in. So we being the vascular surgeon, we need to have that experience and exposure. That is the key point.
But if the theater is a hybrid theater, then it is possible to solve.
Yeah, I mean, in hybrid is another possibility, but also, when the patient is actively bleeding and lost blood pressure, only way to just get open fixation quickly.
Thank you, sir.
I think that's pretty much it.
Thank
So
you, sir.
Abid Bhai, some closing remark, please, about today's webinar.
It's a very good session. I enjoyed it very much. And I think it's a critical issue in all trauma patients, and especially the vascular injuries, critical and life-saving. And I'm sure the experience in Bangladesh, besides NICVD, is limited, but everybody should be at least understand the approaches.
Yeah, absolutely. So Mokbul, I have invited everyone else, but you are not there. So this is a conference coming in May in Greece. It's a very good one, and I am privileged to present 3 papers in that conference. So you're most welcome to give me some support and boost my presentation. I was trying to call Abid Bhai yesterday to convince him that, come to Greece.
Mokbul sir can go, but we cannot, because that NICVD and people who are in the government services leave will be very hard to come by. Mokbul sir is now, I think he can fly like a bird,
Even for a conference, Bashar.
Yes, sir, absolutely. That has become extremely difficult unless you can show the proof of complete support, including the airfare, hotels, registrations, everything being taken care of by the organizers. They will not give you any leave. So how often do you ensure that? How can you?
It sound like you're tethered to the device, huh?
Sorry, Abid Bhai, I missed you.
I say he's tethered with the device in the process.
Right. Yeah.
Absolutely.
Yeah.
No way
So
to move. So
Mokbul
sir
can
now
come.
is free to fly. I think he can do it.
So Mokbul can come. Abid Bhai can come.
Yeah, I'm sorry. I'm sort of limited because of Mrs.
No, I understand.
Limitations.
Yeah. Madam
No,
is sick.
the reason I'm telling Abid Bhai, because I told Abid Bhai that please come in February to Bangladesh, and he agreed. So I thought, as well. So Mokbul, your closing remark on today's webinar. I know you missed most of it though.
No, obviously, this is a subclavian artery injury. This is a management strategy and point is different from other sides, as this is a narrow space here in the neck, and most of the vital structures cross through this narrow space. So there is chance of injury during some time. Taking control of subclavian injury, we injured the subclavian vein as well. So taking control of the subclavian artery, we have to repair the subclavian vein during taking control. Sometimes we have to remove portion of the clavicle also. But this is some sort of difficult work. But sternotomy, thoracotomy, not huge number of cases, but NICVD, when we face that cases, we have to solve the problem. And couple of cases having post-traumatic subclavian artery aneurysm. Yes, endovascular, we deployed covered stent there. It is within the hospital setup, government setup, as well as the private setup also. And still, we have got that facilities also when there is question of pseudoaneurysm or anything like that, we can deploy the covered stent. We have different covered stents in our hand. With these few words, it's a good webinar. So I missed this initial parts, and I will follow your lecture later. And if you send me on Telegram, thank you.
Yeah, no, thanks, Mokbul. I'll send you the slides which I've shown today. And thanks again after your hard day of work to spend some time with us. And thanks again, everybody. I think we had a beautiful evening and afternoon today. Have good discussions. Learn some difficult tips and tricks. So have a good night.
Thank you,
Enjoy
sir.
the rest of the night. And thank you, everybody, again, once again. See you, inshallah.
Thank you, sir. Assalamu alaikum. Abid sir, assalamu alaikum. Madam ke salam diben.
Assalamu alaikum. Wa alaikum assalam.
Assalamu alaikum. Shabai ka salam. Khuda hafiz. Bismillah.
Khuda hafiz.